Okay, guys, so nice to see you all this evening. Thank you all for being here. My name is Mohammed. I'm a clinical radiology registrar based in Liverpool. I've got Jamie, who is a consultant radiologist in the Mersey region. He's MSK subspecialty. And we've got Uzoma here, who's a post-CCT head and neck fellow. He's the fancy one of RadCast, okay? Me and Jamie, we just want to finish our training. So thank you guys for all being here. What we're going to do as part of this talk is just go through the clinical radiology applications. So from the actual application itself, portfolio, MSRA to the interview, and just give you guys an idea of what to expect as part of your application for this year. So we'll start off by talking about RadCast, introduce ourselves, who we are and why we do what we do. Then we'll go through the timelines. We'll mention round 4, just so you guys know it is closed already. They're now accepting evidence as part of the portfolio review, but no more applications can be made. The predominant focus is going to be on round 1, which is still open for applications, okay? Then we'll go through the ranking process. How does it work in terms of the weighting per section? Then the MSRA, the thing that everyone seems to neglect, but has probably one of the most significant parts of your actual application. Then talk about the portfolio and how your verified portfolio score is calculated. Then interview, which I know is a bit far away, but trust me, before you know it, you guys will be preparing for your interview. And then finally, after all this is said and done, how we as RadCast can help you guys really smash your application and help you guys get that lucrative radiology training number, because that's why you're all here. Let's not beat about the bush. Let's address the elephant in the room. You guys want that radiology training number, and we want to help you guys get it. So what is RadCast? Why do we do what we do? Well, let's be honest. Exposure to radiology sucks. As a medical student, whether you're in the UK or abroad, radiology is not something that is given much attention. It's always considered as an add-on. Like, oh, you're with the orthopedic surgeon, why don't you go see the MSK radiologist? Oh, you're with the breast surgeon, go to symptomatic clinic where you may bump into the breast radiology. It's not often a dedicated rotation. Similarly, with F1 and F2 foundation training, you don't really get a rotation in radiology. If you do, you're very lucky, but they aren't really established tracks in radiology as F1, F2. They rather make you do GP, A&E, because those are the clinical type of placements, but radiology, there are very few rotations with it in. But that shouldn't be the case. At the end of the day, we think radiology is awesome. That's why we're radiologists. But also we want to try and expose the specialty for all the great things it has. Interestingly, you'll find that many radiologists aren't aware of the cool things happening in radiology. For example, things like artificial intelligence, things about the impact of Brexit, the impact of COVID. And that's why we made RadCast, to put the specialty up there and expose the specialty for how great it is. So who are we? So we, like I said, we've got Uzoma, who's a post-CCT head and neck fellow currently down in London. There's me, I'm a ST3, currently training in Liverpool. And we got Jamie, who's a consultant MSK radiologist. And in terms of what we offer, the main 3 branches of what we offer is, number 1, we have a monthly podcast where we talk about the exciting things, for example, like I said, artificial intelligence, radiomics, the growing presence of interventional radiology. Secondly, we have education through webinars, like, for example, the one you're attending right now. Try and give you guys that competitive edge when you're applying for radiology, because we want to give you guys that hope and that resource to get into radiology. And finally, the whole point of RadCast is to promote radiology as a specialty, because like I said, we think it's the best thing. I personally never thought of doing radiology back in medical school. It was only in F2 when I kind of realized I didn't want to be the endocrine registrar that I started to look at other subspecialties. Jamie was a core surgical trainee before he went into radiology, and now he's an MSK consultant radiologist. And Uzoma was thinking about anesthetics. So you can see how little exposure there is. And we think that shouldn't be the case, because radiology is probably the best career decision you'll make. So I'll move on to Uzi, who's going to now cover the clinical radiology recruitment timeline for this year.
Unmute and I'll attempt to share my screen. Can you see my screen? Does it say clinical radiology timeline? Okay. I can't hear you, Mohammed, you're muted, but yeah, James.
Yeah, it does. Go on.
Also, yeah, I'm going to go through basically the timeline for the recruitment process this year, which you should all be very well acquainted with if you've started doing your applications, because the window's open. Just a word before I sort of get into it, that we're not going to really go into the Northern Ireland application because that's separate to the rest of the UK, nor are we going to spend time talking about the academic fellowship, because academic clinical fellowship, because that is also a very different application process and it's already closed. But if you want specific advice on the application, the academic application, then you can sort of get in contact with us and email us, and one of us, probably Mohammed, will respond to you very helpfully. So yeah, this time around, the RCR are running 2 concurrent application rounds. There's round 4, which is actually a hangover from last year's application, and a round 1, which is basically the normal sort of application, which is for people starting ST1 in August 2022. So in order to apply for round 4, you need to be able to start from start ST1 between the 1st of February and the 31st of March next year. So a bit earlier than 6 months earlier than usual. So basically, you can't be sort of in foundation to be applying for round 4. So this is the recruitment timeline for round 4. You can see that these were the dates that they published, but so the application period, when you submit your personal details and Oriel, you do your self-assessment, that was meant to be open from the 3rd of November to the 15th of November, but as we now know, that closed prematurely on the 8th of November because there was lots of sort of interest. So that was a surprise for everyone. So it's a bit unfortunate if you were sort of waiting to do your application, but good job if you managed to get your application in and you were sort of on time. So the period for uploading your evidence to support your self-assessment is open at the moment and closes on the 22nd of November. And then the MSRA is going to take place on the 24th of November. So this is for round 4 specifically. And that's the multi-specialty recruitment exam, which we're going to go into in more detail. But that's, sorry, did someone say something?
I'll keep going, Uzi.
Okay, so that's it's the same exam that they sit in GP, ophthalmology, and so on. It's just sort of, it's got 2 parts, which, as I say, we'll go into. And then we don't exactly know when the results are going to be released for the MSRA, but they're probably going to be towards the beginning of December. And then the program preferencing window for round 4 is the 22nd of December to the 4th of January. And initial offers will be circulated the week beginning the 10th of January. And for training start the 1st of February, between the 1st of February and the 31st of March. So that's round 4. So just to sort of summarize that, so long listing for round 4 is based on the personal specifications, just basically whether you're eligible or not. Shortlisting is still going to use the MSRA, and the cutoff score for round 4 for all rounds is unknown at the moment. It changes from year to year depending on how well candidates do. The final ranking for round 4 is going to be based solely on the MSRA and your self-assessment score. So there's no interview for round 4. And at the moment, in terms of where posts are available, we know all it says on Oriel is that there are between 1 and 20 posts in London, and all other deaneries are to be confirmed. Although I did see this is a little bit of insider info, in the guys WhatsApp group, they said that they found out that Kings are getting 4 ST1s in February. So that's some sort of insider info there. But the RCR haven't officially published information on where all the round 4 places are. And this is just a little comment that's written, sort of a caveat or disclaimer that's written on the Oriel application for round 4, where it says that essentially there's an agreement between London and some of the surrounding deaneries, and so it seems like if you do get a round 4 post in London, part of your training could take place in some of the surrounding regions. So just be aware that you could be moved around a bit. So that's something to sort of take into account, but it's definitely not something that would sort of put you off taking a round 4 job. Now on sort of the main round 1 timeline for candidates, which will be for most candidates who are going to start ST1 next August. So the application period for that is currently open. So open on the 4th of November and closes on the 1st of December. So you have a lot longer time to sort of do all of your submit all your information and do your self-assessment. You then have to upload the evidence to support your self-assessment between the 17th of December and the 7th of January. The MSRA window is between the 6th of January to the 15th of January. And then the interviews are on the 21st of February to the 24th of February. It's a bit earlier than last year, and they're going to take place online over on Microsoft Teams, like they did last year. And we'll go into more detail on the interviews in a bit. Offers are going to be circulated on the 14th of March by 5 o'clock. And then training is going to, if you get a job, then you start training on at the beginning of August next year. So the ranking process for round 1 is going to be your score is going to come from 3 parts. So your final overall rank, equal amounts from the MSRA, the verified self-assessment, and the interview. So they're all equally important. So it's important not to neglect any single part. People often neglect the MSRA when it's just as important as the other 2 parts. And the final deanery you get will depend on sort of your how high you preference it and your overall rank. Just a word on competition ratios, because people always like to sort of know about these, some morbid curiosity. So you can see that sort of over the last few years, radiology has been getting consistently or trending to becoming more competitive. Last year, 1,677 people applied, and there were a total of 358 posts. So that's a competition ratio of 4.68. So that is quite competitive. And as you can see on the right, some of the competition ratios for some of the other specialties, in terms of sort of the main hospital specialties, it's more competitive than CST and anesthetics and IMT. But obviously some of the more niche specialties like OPFAL are more competitive than it, but it is fairly competitive and getting harder to get into each year. So Mohammed, I believe, is going to go into a bit more detail about the MSRA.
Thank you very much, Uzi. Let me just get my slides up. Can you all see? Just put a thumbs up, Uzi, if you can. Okay, so the multi-specialty recruitment assessment, MSRA. Every year we talk about this exam. We tell people, please take it seriously. And every year candidates don't, because they find it a lot more enjoyable to go around collecting certificates and letters for their portfolio. So they have a nice thick portfolio that feels rewarding, rather than sitting and learning about the different skin manifestations of psoriasis. Okay, because let's be honest, who likes to revise? Nobody. But this exam, the way we phrase this exam, and I'll come back to emphasize it again, if you smash this exam, okay, most likely you have got your training number in the bag somewhere in the England, Scotland, or Wales. Your portfolio and your interview score will just pretty much decide where you are in the country. That's how important this exam has become, because it's used to shortlist you for interview. Basically, are you even going to get an interview in the first place? And then number 2, are you going to get a full 1/3 ranking points? Okay, so if you have the best portfolio in the world and you don't even get shortlisted, well, that was a good use of your time. It's just an absolute waste. Okay, so please take this seriously. I know I'm going to keep emphasizing this, probably you'll fall on deaf ears, but at least I've tried. Okay, at least we at RadCast have tried to emphasize that, to take this exam seriously. So it's a computer-based exam, originally designed to help with GP recruitment. Then in 2016, and I believe I was a second cohort, Jamie and Uzi were the first year where it was a pilot, but I think the second cohort was officially used as part of my ranking, where the RCR, the Royal College of Radiologists, started to use it to help shortlist candidates for interview, and then also become up to 1/3 of the ranking for the candidates. So it's held in the Pearson VUE centers, which are where, if you've been in the UK, you've had your driving license, so good memories. But if you are eligible, which is a very strict criteria, it's not like, oh, I've got a cough, so I can do at home. There's very strict criteria. For example, you're shielding, then you may be able to sit the exam at home, but it's got very strict criteria as to who is eligible, but even more strict criteria as to the exam conditions. For anyone that recently sat the MRCS exam at home, please note a lot of the candidates were kicked out of the exam, like marks taken away, because their eyes weren't looking at the screen the whole time. It's that type of rigorous nature, okay? So it's not like, oh, I've got a bit of a cold, so let me sit at home. It's very strict criteria. Otherwise, you're going to go to the center and sit the exam there. There's two components. Think about it basically as your medical school finals meets your situational judgment test, rolled up, made a bit more difficult because you're now at the level of a foundation year doctor. There's two components: professional dilemmas, which are basically the situational judgment test questions, the ridiculous things that you'll cover and then be like, I've never dealt with this in my life, but hey ho, now I'm dealing with it. And then the clinical problem solving, which is basically like medical school finals with an alignment towards general practice, because like I said, it was designed from initially to be for GP recruitment. So there's 50 questions for the professional dilemmas. Please note, 8 are pilot questions. You won't get told this is a pilot question because you just probably skip them. But of those 50, only 42 are counted for, and you get 95 minutes. The clinical problem solving, it's 97 questions, of which only 86 are worth any marks, and you get 75 minutes for this section as well. There's no negative marking. Like I said, you won't get told, oh, hey ho, this is a pilot question, because why would anyone answer those, okay? Then when we go to the professional dilemmas, like I said, think about as like your SJT, which I know will probably make everyone start crying in this room, me including, having flashbacks of sitting it. It looks across 3 main domains: professional integrity, how you cope with pressure, and empathy and sensitivity. You would think that just because you've sat this in the SJT, the MSRA, that it's done, but these domains are also now seem to be tested in the interview, and we'll come on to that later, okay? Things like coping with pressure. There's 2 types of questions. Half will be ranking, and half will be multiple choice questions. And the format of how the marks are divided differs. So if you get a ranking question, the max marks you can get is 20. And if you get a multiple choice question, the maximum marks you can get is 12, okay? And here is an example of a multiple choice exam that we've taken from the Pearson VUE mock MSRA, okay? So I'm gonna give you around 30 seconds to do this because I don't want to spend too much time on it. Choose the 3 most appropriate actions to take in this situation. I'm laughing because thank God I never have to deal with this again, touch wood, unless they make it for the consultant interviews now or something. All right, 5 more seconds. So Uzi, what would you reckon? Go on, put you on the spot.
I can't even read that fast.
Radiology is really slow. What are the 3 most appropriate actions?
Oh no, yeah, I wasn't paying attention.
It's all right, okay. The correct answers are C, you explain to the family that is Mrs. Jones' decision. You ask Mrs. Jones whether she wishes to know the test results. And then you ask Mrs. Jones whether she wants her family to know the results, okay? This is like a classical example of patient confidentiality, okay? Barn door, it's not as straightforward as this, all right? Trust me, in the exam, you will get some weird scenarios where you're trying to remember if this is even in English, but it is, okay? And you're just trying to figure out what's going on. One tip I'll give you for this part of the thing is please don't choose contradictory responses, okay? So for example, if you say, give the results to the family first, then you can't be picking, you ask Mrs. Jones whether she wants to tell her family because you've already done it, okay? So don't pick options that are basically contradictory to one another or they're basically polar opposites. That isn't the way to do it. But this is just an example of the multiple choice questions you can expect in the MSRA. When it comes to the clinical problem solving, it's basically like your medical school finals, but not only does it test your knowledge about diagnosis and pathophysiology, etc. But also it goes a bit further and assesses your knowledge about how to deal with scenarios. So for example, emergency scenarios, with what medications are appropriate you should be prescribing. Once again, 50 are going to be extended matching questions and 50 are going to be single best answers. And for this one, unlike the problem solving, this is all about 1 mark per correct answer, and there's no negative marking. As you can see, these are all the domains that can be tested. This is why we emphasize to take this exam seriously. When I was in foundation training, I don't think I ever covered reproductive pathology when I was doing my vascular ward job, okay? When you're doing your TTOs, you're not looking up infectious diseases, all right? I can't remember any types of anemia anymore apart from iron deficiency. So when you're in foundation training, a lot of your common knowledge, your broad knowledge that you had for medical school finals will be lost, all right? If you're on good rotations like GP or A&E, you may have a bit of breadth of knowledge because you've been picking it up with all the variety of cases, especially on GP. But unless you have that privilege, you need to be revising, because if you don't, say, for example, have a pediatrics rotation in foundation, then when are you going to be revising like common skin conditions in kids? You're not. So please remember, this exam is about breadth of knowledge, not depth of knowledge. The more you know, the more you know about a lot, sorry, it's better than knowing a little about a lot. Okay, so just make sure you go away and revise for your, like, say, for example, revising for your finals. So this is an example of an extended matching question. So once again, give you guys around 30 seconds. What, for each patient, which are 2, what is the single most likely diagnosis? I don't think I can get this right without looking at the correct answers, so I'm not even going to bother. Right, 10 more seconds. Okay, so for the first patient, 58-year-old woman who has a tremor and repeated episodes of breathlessness associated with tachycardia, the answer is C, hypothyroidism. And then 2, a 44-year-old woman develops tingling in her fingers 3 days after a total thyroidectomy for papillary carcinoma of the thyroid. The answer is F, hypoparathyroidism. Don't ask me why, because we aren't those type of clinicians anymore. We're now fully radiologists. So if you asked about the imaging, we could have a good go. But this is the type of question you should be prepared to answer in your MSRA. So our top tips: we do not claim to be MSRA experts, nor are we, but we do have experience of either sitting it ourselves or helping candidates focus and prioritize on this exam. The first thing is, please do not neglect this exam. Number 1, it's used to shortlist you. Don't make all your hard portfolio work go to waste by not even getting invited to sit the interview. Yes, you will have to upload the evidence before you've even sat your MSRA, but if you don't even get shortlisted for an interview, then your portfolio score gets thrown out, your application is thrown in the bin. And then finally, once you do get shortlisted and you get your portfolio verified and you do then go to interview, it's worth a third of your final ranking, 33%, okay? And what we say to candidates is any marks that you lose in your portfolio, you can make up in your MSRA, same for interview. So if you had some last minute nerves or you weren't able to get those publications, then your MSRA can make up for it. In 2021, last year's application cycle, the shortlist cutoff was 525 to 527, okay? And if you met that, just remember that even if you meet the cutoff, you get ranked, and it's often the top 600 candidates who get invited. And if you don't meet the top 600, but you are meeting the cutoff score, you then get put on the reserve list, all right? You do need to revise. This isn't always a GP exam, so I can just blitz it and I can revise a day before. It's none of that, okay? I remember getting questions about the immunization schedule for the United Kingdom. Unless you revise that, you're not going to figure it out on the day, okay? So it is a lot of content that you need to cover, and it's all about breadth of knowledge, not depth of knowledge, okay? Then revision does take time, especially now that most of you are practicing doctors. It's not like medical school finals where you wait for the last 2 months and then just go hardcore. You have to plan it out and pace it out, otherwise you'll burn out. And now is the perfect time to start, especially with the MSRA for the round 1 being in January, okay? And like I said, any marks that you lose, you can make up in the MSRA. In terms of resources for the more situational judgment type, if you haven't read this, please do so. This is what is basically expected of you as a doctor, the duties of a doctor, so to speak, and it'll outline some common ethical scenarios that you should deal with. And it's not about what you just don't respond to the answers based on what you've seen in practice. That could be horribly wrong, okay? It's about what the General Medical Council advocates, all right? Or what is best ethical guidance. Then this scenario is pretty cool, I think. Basically, they have these scenarios and you can choose answers. And depending upon what you choose, you see the repercussions. So it's a very good like resource to use in terms of just seeing common ethical scenarios that can come up. So for example, this one where the person is including depression, anxiety, and how you deal with that as a clinician. These are the 3 textbooks that we recommend. So for the clinical dilemma scenarios, go pick up your Oxford handbooks, all right? Your clinical specialties one and your clinical medicine one. Just try and go through as much knowledge as you can. For the SJT, we recommend this Oxford Assess and Progress. Why? Because the actual explanations are linked to good evidence, all right? It's not just me saying, oh, I would do this, and because I'm the publisher, I'm right. It's no, in GMC, it says you should do X, Y, and Z. So then you can go away and read further if you want to, just to get your head round why you're doing certain things. Now, when it comes to question banks, there are a lot of them, all right? The 3 big ones are Past Medicine, Past Test, and MCQ Bank. Of the 3 that we know, the one we recommend from day 1 is MCQ Bank, all right? The reason why is because when we sat the exam and when we've spoken to candidates who've sat the exam recently, they say questions in the MCQ Bank seem to repeat in the actual real life exam. The reason why is because a lot of the questions on MCQ Bank are basically candidate submissions. So they've sat the MSRA themselves and remembered the questions and then they're submitted, okay? So it's such a good feeling to have when you see a question in the real exam and you smash it, okay? Smash it for 6 because you've done it before. Now, this is the discount code that we have exclusively for RadCast. Please remember the R and the C are capital letters, okay? But it's RadCast 6M, and we would recommend MCQ Bank as your predominant primary revision. Please don't get all 3 question banks to make yourself feel better. It's a waste of your money. But also it's about going through one question bank in its entirety because you get breadth of questions. And then once you're happy that you understood why you got things wrong, then moving on to maybe a second question bank. But don't overdo it by getting 100 books, 100 courses, going to every course there is out there, because you're not going to go through it all and then you're going to panic when you realize you haven't even done one question bank and your MSRA is now 2 weeks away. All right, so focus on one, blitz through it, and then if you have time, go to another question bank. So that's me done in terms of the MSRA. I'm now going to hand over to Jamie, who's going to cover the self-assessment and the portfolio station.
Hi guys, so yeah, we'll talk about the portfolio now. So the self-assessment is done online on Oriel. Candidates are asked to score themselves across 5 domains and give their score before the registration closes. And then after that, there's a time period from the 17th of December to the 7th of January where candidates can upload the evidence for their scores. That's then reviewed by a panel who will then verify your score. So The 5 key domains are research into a career in radiology, degrees and qualifications, audit and quality improvement, teaching, and then research and academia. And each domain is worth 2 points, which gives you a potential total of 10. So then I'll go into each domain in the coming slides. So once you've submitted your application, you cannot actually amend your score from that point, and only achievements that have been completed by the deadline day will actually count. There is a small caveat to that with publications, whereby if it's been accepted, as in they will be putting it in print, it's finished the review process and everything, then if you have proof of that, then that will be okay. So you'd still get the marks for that publication. So because of the way you're scoring yourself, there is potential for small discrepancies in the score when they come to review your score. But if you're seen to be consistently overclaiming, then that becomes more of a probity issue and will more likely result in a GMC referral rather than a radiology training post. So it's best to be completely honest with your scoring, as opposed to trying to wangle things to give yourself a bit of a bump. Some achievements can be used to score points in multiple domains, apart from audit and quality improvement projects. And also any achievements before medical school don't count. So we'll go on now to look at the domains in turn. So we'll start with research into a career in radiology. As you can see, they are very specific about what is required to score points, even down to the number of days that would count for a taste that what we would previously know as a taste a week now is taste of 3 days plus. So to score top marks, you need to spend enough time in the department, and as part of that, get a project done. Otherwise, you're just going to end up with 1 mark. So if you spend time in the department and that's it, then that's 1 point. So you really do have to be looking at getting a radiology themed project out of your taster session to get that 2nd mark. And actually, even if you show that you've been in the radiology department for a day and that's all you've got, then you're not going to score any points for that. So here are some of the ideas for what you can do to get that 2nd mark, in addition to spending time in the department. So we have our course that we offer. There's the Royal College of Radiologists annual conference. They also have a list of audit recipes on the RCR Audit Live templates. So they tell you what the audit standards are, how many people you need to, what your sample size needs to be, etc. So it's really well laid out there, and there's plenty on there that are very straightforward to do just from PACS databases. And then, yeah, so any research that you've got in radiology, prizes, that would include the prizes that we have on offer as well. And then any clinical placements that you might have or teaching experience. So on to qualifications then. So once again, the college are very specific about what scores points and what doesn't. And one thing to note here is that the points are allocated differently depending on where you are in your career already. So there is an expectation to have qualifications that are commensurate with your experience. So for example, Part 1 MRCS will score you 2 points if you're applying straight from F2, but you're going to need the full MRCS if you're past F2. But then if you qualified for medical school over 4 years before applying, then the full MRCS will only score you 1 point. So there's kind of like diminishing returns to the value of that exam there, depending on where you are. And then also with degrees, the class that you get in that degree will affect what points you get as well. And then obviously you're not going to get any points if you don't have anything additional. So clinical governance and postgraduate quality improvement and audit. So to hit 2 marks here, you're going to have to lead 2 projects and present at least one of them at minimum regional level. There's more importance placed on closing the loop as well, and also on leading the project versus just being in a team doing it. It's actually possible here, if you look at how they've written it, to score 0 and be involved in an audit. So you have to be really careful and make sure that you have significant involvement and that you actually see the project through. So teaching now. To hit the top points, you need to have a recognised postgrad teaching qualification, so like a postgraduate certificate or diploma in education. or a master's in medical education or something like that. And if you're organising a teaching programme as your main driver for the teaching points, then it has to be a regional or national teaching programme, because a local programme will only score you 1 point. Informal bedside teaching or case-based discussions or something won't score you anything. It has to be formal teaching. So I think by formal, that would mean it's something that's a pre-planned session through the education centre in your hospital or whatever, and then you should be getting feedback from that as well, and that's going to get you 1 point. If you don't have any teaching experience, then you're not going to get any points at all. So research and academic publications. 2 points here, if you're coming straight from F2, are really tough to get. So you need a PhD or an MD, or you need to be first author in 2 publications or co-author in a radiology publication. So, and then you're only going to get 1 point if you've got publication as a first author. So yeah, it's really difficult here to get maximum points, unless you're really sort of straight out of the gates with getting publications in F1. If you're applying straight from F2. So you can also score points here if you've been a co-author, but then you will also be having to present at a radiology national or international meeting. And obviously, if you've got none of these, then you're not going to be getting any of the points. So I think with the way the college have written these criteria this time round, it's quite easy to say where you should be getting marks and where you shouldn't. So it's kind of, there's less that's left up to people being able to twist things or more opinion on it. But ultimately, this score that you give yourself is still then going to be verified by someone in the college. And if they don't agree with you, then they will adjust your score. There is an appeals process for that, but that's not something that would be happening, within the application cycle. So I'll now pass you back to Uzi, who will talk more about the interviews. Thanks for listening.
No worries. Mohammed, do you want to clarify about the scoring for the publications?
Okay, so
this is I think this might be last year's. That might apply to last year.
Fine. So I think it doesn't need to be a radiology publication per se.
Yeah,
I think that's the change. Obviously, yeah, but I think just we'll change that. Don't worry, we'll upload it onto our website. But also, just please remember, for those of you, I don't know how many in the room have applied to round 4 and are now submitting their evidence for round 4. The portfolio criteria for round 4 differs to the new round 1. Okay, so don't be like, oh, I've given my round 4 a score of 10 out of 10. So I'm going to give my 2022 August application a 10 out of 10 as well. Please just double check, okay? Because round 4 is closed, we haven't really talked about the portfolio score here, but please just double check for those of you applying. Whilst Uzi's talking about the interview, because there's a lot of portfolio questions, I'm going to try and respond to you guys, okay? So just bear with us. If I don't get through to us, you can email us if you want to, but I'll try my best to respond to all the portfolio questions that are just like filling the chat now, right? So I'll hand it over back to Uzi.
Okay, so I trust you can see my screen. So I'm going to go over the interview, okay? So as was the case last year, they're keeping the interview structure the same this year. So it's a single 15-minute interview station, which is held over Microsoft Teams. So you're quite fortunate this year to know what the structure is in advance. Last year, they dropped this on the candidates on the first day of interview. So, and this particularly penalised those candidates who went first because they had no idea that they'd be asked these sorts of questions. So yeah, they can change the interview at quite short notice. So the structure last year was 2 minutes on commitment to specialty, 5 minutes on coping with pressure and managing uncertainty, 5 minutes on team involvement, and then 2 minutes on attributes and skills. And then they left candidates with a final 1 minute to add any information to support their application. In terms of the feedback we've got from candidates who did our courses last year and fed back to us what came up in the interviews, they didn't really vary the questions that much. So there was a lot of repetition. So in terms of the commitment to specialty section, some of the questions they asked were, why radiology? Tell me about the training pathway in radiology, and what is the biggest challenge facing radiology? So they're fairly sort of standard questions that you should be preparing for and have good answers for. So those are some of the questions that we know got asked, but there's a whole range of other sort of radiology topics that they could conceivably ask. They could conceivably ask about exams, academies, skills mix, you name it, and all of these hot topics in radiology. So we have modules covering lots of these topics, 19 separate modules, covering different areas of topics in radiology for commitment to specialty. And then also with our podcast, we cover a lot of hot topics and current issues in radiology. So people do tend to pick up sort of gems which they drop in their interview from our podcast. So we would recommend you listen to those. And then for part B, so coping with pressure and uncertainty, with this section, there was basically, they either asked you a direct question or they gave you a scenario. So with the direct questions, again, fairly straightforward. Give an example of when you coped with pressure. And then with the scenarios, it's interesting that you were always an F2. So sometimes you think you should practice scenarios as a radiology registrar, and who knows, this year that might be the case, but last year they always put you in the shoes of an F2, but it's similar to the scenarios you'll get in your sort of MSRA. So one particular scenario that came up a lot was you come onto the wards to start to do the ward round. The senior hasn't started the ward round yet. A nurse tells you that they're in the doctor's room crying, and so you have to go in there and sort of manage the situation. And the cases evolve depending on how you tackle them and how well you elicit information. And so, yeah, you had to sort of adapt as the case evolves. So quite left field. So it's not what you're expecting in a radiology interview. So be prepared for these sorts of questions. The next section, team involvement, again, either a direct question or a scenario question. Generally, if you've got a direct question in the pressure section, then you got a scenario question for team involvement and vice versa. So in terms of team involvement, the direct question that came up a lot is give an example of when you've worked well in a team or led a team. And the scenario, again, as an F2, a colleague is having difficulty on the job and confiding you that they're struggling with their mental health, and again, sort of you have to handle that situation carefully and elicit the information in the appropriate way. So a common theme is sort of trying to deal with difficult colleagues or colleagues in difficulty. So they're obviously placing a lot of emphasis on trying to get people into radiology who've got good morals, which I suppose is a good thing. And in these questions, they can be quite difficult to know how to answer them, but particularly if you don't have a structure, you can end up just waffling and going down the wrong path. But there are sort of ways that you can tackle these in a nice structured way, and basically just like a driving test. And so we have a whole module on how to answer these sorts of questions, giving you a framework for answering them on our course. And then, yeah, in terms of attributes and skills, so what makes you suited to a career in radiology, or provide evidence that you're suited, and you can talk. People spoke about like strengths and weaknesses, the roles that they've been in, and or their time management skills, achievements, teaching. So just general things that your skills, your attributes and skills that make you suited to radiology, essentially. So yeah. And then any additional info, this was quite difficult to plan for. I suppose try and think of anything relevant that hasn't already come up yet. It's probably useful to go in with a mental list of things that you really want to come up in your interview, any projects or achievements that you're really proud of. And if they haven't come up in the first 40 minutes, then you can bring them up in that 1 minute extra that you're given. And yeah, so in terms of the interviews, just sort of a general point, candidates did feel very time limited. There was no time for pleasantries. It was basically get in, barely introduce yourself, and then you start. And then as soon as the 50 minutes were up, an invigilator cut you off, wished you good luck, and then sent you on your way. So just don't be prepared to be thrust into there straight away, and for it to whiz past, and then for you to be kicked out essentially. So I'll pass you back to Mohammed now to finish the talk.
Okay, guys, so this is the last bit of the talk. Don't worry, we will be around afterwards to try and field any more of the portfolio questions. I've tried to make a dent. I don't know if I've made a dent, but we'll try our best to go through. Jamie's just shaking his head. He gave up a long time. He's like, yeah, whatever. You get on with it, Mohammed. So this is probably the second most important bit of the talk. Okay, the first bit was telling you about the application in a nutshell. This is now how you can maximize it. You guys have very limited time left. All right. It's not a case of, oh, there'll be very few of you who are like, oh, I'm applying next year. In your case, you've got plenty of time. For those of you who aren't, majority of you like, okay, I've got a few weeks to try and blitz as much as I can. So rather than telling you generic useless crap like, oh, go do an audit, like you don't have time to go do an audit unless it's like something ridiculous, short. I don't know, like, does a radiologist know about the anaphylaxis pathway? All right. So the way you need to be doing it is through what we call the RadCast way. All right. Now, we work smart. I think we all do at RadCast, right? We don't work hard. We like to work very smart, be as efficient as we can with the limited time that we have. All right. Like I said, you guys don't have the pleasure and the pleasantries of having as much time as you want to work on publications. If you're thinking of picking up a publication now, please go in the mirror, slap yourself. The answer is no. Okay. You're not going to start a case report or a meta-analysis at this stage. All right. It's too late. Just accept it. Don't waste your time sitting there after 5 p.m. writing up a case report. It's not going to get peer reviewed in time. And things that are not done by the time of deadline submission, which we'll talk about, they're not going to count. All right. So how do we work smart? There are 3 main domains that we think you can still plug the gaps in. The first one is the commitment to specialty one. All right. Because commitment to specialty is a very easy thing to prove. All right. And one thing that we have that we think can genuinely help is our radiology crash course. Now, we did this back in August as like a one-day event, and we were due to kind of revamp it to a conference for next year. But one thing that we noticed was a lot of foundation doctors doing it for commitment to specialty. So we've been telling candidates that, yeah, we're going to keep enrolling you. And we've kind of said, actually, let's keep enrollment open till the end of the actual application window. So this course has been designed to give you that introduction to radiology. Now, there are other courses out there, and I'm not saying we're the only radiology course there is, because that would be a lie. But one thing that we do that's different from everybody else is we know why you're coming to our course. It's to get commitment to specialty. All right. It's to learn the basics of radiology beyond the chest x-ray, but it's also to show commitment to the specialty. And that's what exactly our certificate says. All right. It's a half-day course. If it takes you longer than half a day, you're taking a sweet time. Okay. Half a day, 14 modules, blitz through it, and you'll get a certification that says specifically on it, you've shown commitment to radiology specialty. Okay. The thing you guys have to remember, that is what I've been saying to people in the chat, the novelty of justifying your score to a assessor face-to-face, like I did when I applied, is not going to be there this year. Your application is going to go to a nameless and faceless person that's a consultant radiologist. He or she will pick up your portfolio, your online evidence, and go through it. If they don't feel confident giving you the marks, they're not going to go and do like a literature review about this thing that you've done. They'll probably be like, I'm not really sure what they've talked about, so I'm not going to give them the marks. Okay. And you're not there to be like, what are you talking about? This audit was about this. You don't have that. You don't know until you get your score in January. All right. So our course, 14 modules, half a day. We're still taking enrollments. We've just decided blanket to allow people to apply till the end of the application window. If you're interested, please go on the website there on the link you can see there and just send us an email, so then we can do the rest in terms of just getting you enrolled, etc. So that's the first one. The first domain we think you can plug is your commitment to specialty one. The second one is the teaching domain. All right, let me clarify a few things. The first one is about how you get 2 marks versus 1 mark. For top marks, you either need to have a PG cert, or you need to be like a faculty member of like a teaching institute, or you need to have regional or national teaching. People have been asking about regional, the definition. I'll give you a real example. If I go and teach at my hospital, let's say, for example, Arrow Park Hospital, I've given local teaching. If I decide to then teach the whole of the Northwest, that is a regional based teaching. And if I decide to teach the whole of England, which is quite interesting, like this is probably international teaching if we wanted to go for portfolio points, because we know we're getting international applicants, then it would be national/international. You've got to be very specific about that evidence. Unlike medicine, unlike surgery, there is no time specification from radiology. It's not like you have to have done this for 3 months or 6 months, or you have to have delivered 6 sessions. Radiology isn't as militant as those other two, despite being more competitive, which is interesting. Okay, so the other thing is that for 1 mark, you need to do like just basically like ad hoc teaching. Or one of the things you can do is go to a Teach the Teacher course. Once again, there's loads out there. The difference between them and us is that ours is radiology focused. Okay, we like to give a radiology slant to it because we're radiologists. So you can start to try and plug in the commitment to specialty because you've actually developed teaching interest in radiology as a specialty. The second thing is it's online right now. You can plug in when you want. It's available 24/7. And if you want to, there is an opportunity. It's purely optional to deliver national/international teaching, okay? And once again, the certificate's issued upon the short assessment, which is a reflection piece, which is pretty much easy peasy, okay? Teaching is another domain that you can easily plug in, all right? Commitment specialty teaching, we think you still got time. The other domains, audits, unless you're doing something really easy like Ottawa knee rule or ankle rule, you're going to struggle to get all the data. Research is a no-go, all right? Just stop. Anyone that's still writing a publication, just stop. And additional degrees, well, that's pretty much obvious, isn't it? You're not going to do an MRCS randomly in a week's time, okay? And then finally, we have our application course. So it's 60 modules, 5 hours of content. Now, we made this course because when I was applying, there were courses out there, right? I and Jamie and Uzi, we made this for a reason, because we were kind of frustrated with what existed. The other courses out there, you go there, often end up going to London for some bizarre reason, spending more money on like hotels and travel. And then you go there and then you don't have anything to go back to, all right? Our course is all online. Of course, you can speak to us and we do these like talks to help you guys get some more knowledge, but there's entire sections dedicated to specific parts of the portfolio and the interview. For example, because of the changes for last year, we've made a dedicated ethics section and a model answer section. So for example, if they ask you, can you give me an example of when you've been a leader? We've got a module that shows you how to frame that answer correctly. Secondly, if you want to try and build your prizes section, we have national prizes up for grabs, which will be certified before the end of the application window. And we've bundled them in with interviews, so you can kind of mix and match the perfect package for you guys. And this is an example of some of the modules that we've covered in terms of the content. So for example, really common interview questions like why radiology, which got asked multiple times last year. Then if they want to throw in curveballs like what is skills mix, what is teleradiology, you'll have an idea of what to say. So we used to say beforehand that we were the most comprehensive clinical radiology interview course or application course out there. We now say we're the most comprehensive resource out there. That's the whole package, okay? And in terms of success rates, if this matters to you, which I think it should, in 2021 to 2020, 2019 to 2020, we had 100% success rate. And then in the 2020 to 2021, we had 99%. The thing that caught people off last year was the interviews, okay? So some people didn't go with us for the interview prep. They just used our application course. And then when the ethics got thrown in, they just kind of just like did not know what to say because they weren't prepared for that. So of course, we've fixed that. We've got now ethics section, which will hopefully cover that element of the interview. So if you're interested in any of our courses, bundles, you want questions answered, please just email in on us. We're very flexible. We're very happy to speak to you guys. At the end of the day, we want to help you guys get your training number. What we'll do now is we'll be around for another 5-10 minutes, answer as many questions as we can. And then we'll post this video once it's been rendered and everything onto our YouTube channel and onto our course platform, okay? So I'm going to stop sharing my screen. You can just go on www.radcast.co.uk and you'll find our email there as well. So let's try and go through the questions.